Okay, it's already 9, so I think I will start my lecture. Assalamualaikum and a very good morning to everybody. My name is Dr. Fatimah Muhammad. So today I'll be teaching you the third topic of pathology, which is the non-neoplastic bone diseases. Okay, so for this topic, I think first of all, you have to mute all your microphone. And then if you have any question, we will discuss this at the end of the session. Okay. So for this lecture, dengar
Dengar, doktor.
Okay, thank you. Macam cakap seorang. Okay. Okay, so for the this topic, we will learn about osteoporosis, number 1, and then osteomalacia and rickets, number 2, and last would be the Paget disease of the bone. And among these three, the most common would be the osteoporosis. And for each topic, for each disease, you will have to learn about the etiology, pathogenesis, morphology, clinical manifestations, and complications. Okay, so these are the knowledge that you need to know about this disease. Okay, and then for the skill at the end of for this topic, you have to be able to identify morphological features of all these three. When I say morphological, that means you have to know the macroscopic and microscopic, or the gross and microscopic for each diseases. Okay, and again, these are the contents that I will cover in these topics. Okay, so we will start with the first topic, which is the osteoporosis. Okay, I think you have heard about osteoporosis before. It's quite common. It is defined as decreased bone mass that is severe enough to have a risk of fracture, meaning that with a simple injury or simple fall or low impact injury will actually will contribute to the fracture. So this is called osteoporosis. The World Health Organization, WHO, defined osteoporosis as bone mass at least 2.5 standard deviations below mean peak bone mass. Don't worry about this. What you need to know is they gather a normal patient. So they found that the bone mass for normal patients is around this, the T-score. T-score is the standard deviation. When it falls between this, it is considered or categorized as osteopenia. Osteopenia is also reduced bone mass, but can you mute your mic? Everybody mute your mic, yeah? Okay. So for the osteopenia is also a reduced bone mass, but the risk for fracture is not as severe as osteoporosis. Okay, it does not increase the fracture of the risk of fracture. But when it is osteoporosis, it is falls under the T-score of less than 2.5. This is the definition of osteoporosis by the WHO. But I think for you, it is sufficient if you know the osteoporosis is decreased in bone mass. Okay. So osteoporosis is categorized into two, which is number 1 is the primary and number 2 is the secondary. Among these two, primary is the more common osteoporosis. Under primary, you have postmenopausal and senile osteoporosis. Okay, postmenopausal is osteoporosis which occur after menopause in female, and senile osteoporosis is age-related osteoporosis which occur in elderly patients. And secondary osteoporosis can occur at any age, provided the patient have other underlying pathology, for example, endocrine disorders, gastrointestinal disorders, and taking drugs, certain drugs. Okay, this I will describe later. Primary is more common than secondary. So look at the secondary. I just want to show you there are a lot of causes of secondary osteoporosis. I will elaborate further. Yeah. So primary, secondary categories of osteoporosis. Okay, now let's move on to the pathogenesis of osteoporosis. So before I tell you about the pathogenesis, you have to know what happened in our normal body. So we will have the bone mass will peak until we reach the third and fourth decade of life. So you are at the second decade of life. So you better get your you better make sure your diet is good. You have a good lifestyle so that you can have a peak bone mass. Great. So if you have a greater peak bone mass, they will actually delay the onset of the osteoporosis. Osteoporosis will occur. I mean, because at the when we reach third or fourth decade, like me, I will lose my bone around 0.7% per year. So each year there'll be bone loss, and mainly at the spine and the femoral neck. Okay, so these are the crucial age to get the greater peak bone mass. Okay, so I just like to recap of the bone remodeling, because after you reach third and fourth decade, your bone absorption will outpace the bone formation. So you have the resting stage here, and then you have recruitment of the osteoclast. Osteoclast will be responsible for bone resorption, and then there'll be a transition phase whereby the osteoclast will be removed and will be replaced by the osteoblast. Osteoblast is the one that is responsible for the bone formation, and then it will go back to the resting stage again. So bone remodeling is the continuous process. The role of bone remodeling is actually to remove the mature bone and replace by the new bone. So this diagram is from your Robbins. It is very, very important. Okay, so you have to remember this. So physical activity, genetic factors, and nutrition will determine your peak bone mass. Okay, and then as I mentioned before, after the third and fourth decade of life, depends on your peak bone mass and depends on other occasion like menopause for female and aging for both. It will eventually lead to osteoporosis. Okay, so these are the risk factors for the osteoporosis. Okay, let's go one by one. What happened in how does age influence the osteoporosis? Okay, age related changes will cause senile osteoporosis, which occur in elderly. Okay, you know, the osteoblast is the role of osteoblast is to form the bone formation, for the bone formation. So osteoblasts from the older individuals are different if you compare with the younger individual, because number one, there'll be reduced proliferative capability, and biosynthetic potential is reduced in osteoblasts from older individuals, and they have decreased replicative activity of osteoprogenitor cells, and then there is a decreased synthetic activity, and the growth factor will also be diminished. Okay, and then this will reduce and then for the elderly, usually they will have reduced physical activity. So all these factors will contribute to the osteoporosis. Okay, so the net result will be osteoporosis. However, because it has a problem with the osteoblast reduced capability to proliferate, biosynthetic potential is reduced. However, the osteoclast remain the same. That is the problem. Okay, so that's why it will eventually leads to more bone resorption. Okay, reduced bone formation in elderly. Okay, and then number two, how hormone influence the pathogenesis of osteoporosis. So postmenopausal will have estrogen deficiency, right? Around 40% of postmenopausal women would have osteoporosis. Okay, how does it occur? Okay, first of all, you have to know this diagram is also from your Robbins. So what happened in the this diagram is showing the how osteoclast is formed. Okay, so this is your osteoblast. This is the osteoclast precursor. So at the osteoblast, we have the rank ligand, and at the osteoclast precursor, we have the rank receptor. So the rank ligand will bind to the rank receptor, and this will stimulate the osteoclast precursor to be differentiated into the osteoclast. Osteoclast will cause bone resorption. Okay, and then the stroma will produce something called osteoprotegerine, and this osteoprotegerine will block the rank ligand and interfere with the interaction between these two. So if you have reduced in osteoprotegerine, there is nothing that interfere this interaction. So you will have more osteoclast to the osteoclast precursor to be differentiated into osteoclast. So what happened when a female had a menopause? So there will be low estrogen, right? So when there is low estrogen, there will be increased cytokines. These are the cytokines. So these cytokines will actually increase rank ligand, diminish osteoprotegerine. Therefore, it will increase osteoclast activity. More osteoclasts will be differentiated into active osteoclasts, and it will also prevent the osteoclast apoptosis. So these are the mechanism of osteoporosis in patients with menopause. Please mute your microphone. Okay. Can you please mute your microphone? Okay, thank you. Okay, so in postmenopausal women, there is some compensatory osteoblast activity, but it is inadequate to keep up with the osteoclast bone resorption. So basically what I'm trying to say is an osteoporosis because of reduced estrogen, increased cytokines. Cytokines will actually increase the osteoclast activity. Okay, that is the mechanism. Again, as I mentioned, these are what I've said just now for aging, for senile osteoporosis, and for the menopause. This diagram is very, very important. Yeah. Okay, how does physical activity influence the osteoporosis osteoporosis? So the decreased physical activity contributes to senile osteoporosis because you need mechanical forces to stimulate bone remodeling. Because when we exercise, the skeletal muscle will pull against the bone and actually stimulate bone remodeling. And they have found that a resistant exercise like weight training is more effective for bone remodeling as compared to cardiovascular like cycling or jogging. Okay, so resistant exercise is also important. Okay, and genetic factors also contribute to the peak bone mass because they found that those with vitamin D receptor polymorphism will actually influence the peak bone mass in the early life, and some single gene defect and other polymorphism will also determine the peak bone mass in certain population. Okay, and last, the nutritional, your calcium and vitamin D is very crucial in to determine the peak bone mass. Okay, so at this age, please make sure that your calcium is sufficient and you have a good sun exposure. Okay, to achieve the peak bone mass. So if the peak bone mass is not achieved accordingly, so they are more likely to develop osteoporosis at an earlier age. Okay, so the nutrition, the physical activity, and the hormonal all influence the peak bone mass. Whether you will have osteoporosis, it will delay or make it early. Okay, so in summary, these are the risk factors for osteoporosis, like what I've mentioned before. Okay, it's all in your Robbins. Okay, just now is the risk factors for osteoporosis, and now I would like to tell you about the secondary causes of osteoporosis. So I know you have not learned all this, but I will try to explain just a brief explanation. Yeah. So if if the patient have insufficient hormones, okay, in endocrine deficiency like hypogonad or ovarian failure, they can have low testosterone, they can have low estrogen. This will also contribute to the osteoporosis formation. By the way, if there is the hormone is excessive, certain hormones like if in body you have cortisol, you have thyroid hormone, and you also have parathyroid hormones, all these hormones will actually increase bone resorption. Yeah, so it will lead to osteoporosis. And malnutrition, malabsorption, gastrointestinal disorder will call you to be malnourished. So less vitamin D, less calcium will be absorbed. Okay, and then bone marrow malignancy, all these, the drugs, all these will actually increase bone resorption. And they have found that alcohol and smoking can actually interfere with the function of the osteoblast for the bone formation. Okay, so these are the cause of secondary osteoporosis. So when you have a patient, a younger patient, to have osteoporosis, so definitely it will not be the primary osteoporosis, because primary is your postmenopausal and senile osteoporosis. So you have to think whether the patient is having secondary osteoporosis. You have to look at the other manifestations that may suggest secondary osteoporosis. Yeah. Okay. So as for the morphology, the hallmark of osteoporosis, histologically, the bone is normal. Okay. However, it will be decreased in quantity. Okay. So this is the normal bone, and this is the osteoporotic bone. You have the cortical bone here. You have the trabecular bone here. So what happened is the cortical bone will be thin, okay, and there'll be a reduced thickness of the trabeculae, and the interconnection will be lost. Okay, so once enough bone is lost, so the patient will be susceptible to the fracture. Okay. Again, this is another gross specimen showing osteoporotic bone. This is the spine, the vertebrae. So look at the cortical bone is very thin, right? And then this trabeculae is also reducing. So the patient is having compressive fracture. So they will manifest as loss of height, ketinggian kurang. Okay. So because of the vertebrae is reducing, not reducing number, it's a compression fracture. Okay, for the histology, this is the normal bone. This is the osteoporotic bone. This is your marrow, and this is the trabeculae. Look at it; it has a very nice trabeculae. But what happened here? There is trabeculae, but however, it is thin and it is sparse. Okay. So the histologically, it is normal. However, it is reducing in number, very thin and very sparse. Okay, so this is osteoporotic bone histologically. This is another picture showing a thin and sparse trabeculae. Okay, clinically, how they manifest. So most of the patients with osteoporosis will be asymptomatic. They don't have any symptoms until they have a fracture. Okay, so common clinical presentation would be kyphosis or scoliosis. What is kyphosis? Okay, this is the normal body from the lateral view. Lateral view is from the side, pandangan dari tepi. Okay, so this is the lateral view. For the normal person, we have a very nice S-shaped vertebrae, the spine. Okay. However, when the spine is kyphosed, it becomes like this. I imagine that this is the K, right? Kyphosis, K. Okay. So lebih kurang lah. Okay. So because of the whether the patient is having compression fracture here, so they can have kyphosis. Okay. Another, your spine from the back should be straight. So scoliosis is when it is deviated a bit to the side of the body. Okay, so this is scoliosis. So some patients, they can have both. They can have kyphoscoliosis, chi and scoliosis. So this is not good. And they will manifest as uneven shoulder. They can have a curve in the spines and also uneven hips. Okay, so this is that is the manifestation. And they can also have low trauma fracture, Colles fracture. Simple injury, meaning that they can have a fracture at the wrist, and then they can have loss of height. See, this is the compression fracture. Lama-lama dia be loss of height. Okay, and usually they will manifest as back pain. Okay, if the kyphoscoliosis is very severe, okay, it will interfere with the respiratory function because here you have the lungs, kan? So if you have kyphoscoliosis, the rib cage is not normal, so it will interfere with the expansions of the lungs during respiration, so it will compromise the respiratory function, okay? And those with fracture, usually they will be immobilized, so they can have a risk to get pulmonary embolism. You will learn this in your cardiovascular disease and respiratory disease. Pulmonary embolism is when the thromboembolism, like a big blood clot, the embolus travel to your pulmonary. So you will be, the patient will be breathlessness, chest pain, and prolonged immobilization may also result in pneumonia, and because of the kyphoscoliosis as well, okay, or the fracture. Okay, that are the clinical manifestations. So osteoporosis, however, cannot be reliably detected in plain radiograph. Plain radiograph is like your X-ray, because when there is bone mass loss, X-ray changes will only be visible when there is 30 to 40% of bone loss. However, there is another method to actually detect osteoporosis early by using DEXA scan, because if there is only 1% changes or bone loss, you can actually detect the osteoporosis, but not with the X-ray. Okay, and a measurement of biochemical investigation like calcium, phosphorus, alkaline phosphatase. Alkaline phosphatase is the ALP. I mean, short form is the ALP. ALP is synthesized by the osteoblast. So not very helpful, especially in those with postmenopausal and senile. They can have a normal biochemical investigation for osteoporosis, and therefore osteoporosis is quite difficult to screen, especially when they are look for the bone loss. To detect osteoporosis is the DEXA scan, not the X-ray, okay? Because the X-ray will detect late. So biopsy is rarely performed to detect by osteoporosis. Osteoporosis usually is by the clinical manifestation, the history, and by the DEXA scan. This is the summary for what I've said. So when you suspect the patient to have osteoporosis, usually the calcium, phosphate, and ALP will be normal, especially in postmenopausal and senile. And sometimes they will do other tests like thyroid tests, parathyroid tests, because they want to rule out secondary osteoporosis if it is suggestive. Okay, so these are the investigation that normally done in those with osteoporosis. Okay, so we have another markers, bone resorption markers, that we increase if the osteoclast activity is increased, and bone formation tests that be increased if the osteoblast activity is increased. All these are not routinely done, not widely available, just in some centers. But ALP is somehow is widely available, and you can it will be increased if there is increased osteoblast activity, bone formation test. Okay, and then how you prevent osteoporosis. So you need to have a good lifestyle modification, discontinue alcohol or smoking, and need to have a good diet. Make sure the calcium and vitamin D are sufficient, and if the patient have symptoms, they will be given adequate analgesia for the pain, painkiller. And then if the bone resorption is increased in some patients, so there is some medication that is anti-resorptive, like biphosphonate, calcitonin, and estrogen, and sometimes they will be given anabolic agent. Okay, so these are the prevention and also treatment for the osteoporosis. Okay, now we've done with osteoporosis, so let's move on to another topic, which is the osteomalacia. Okay, osteomalacia and rickets are a similar condition. It is due to vitamin D deficiency. So when it occurs in adult, it is it occurs in children, it is called rickets. Okay, so why is there any difference in terms? Because in children, nantilah cerita. Okay, the osteomalacia is actually the softening of the bone, and it is characterized by inadequate mineralizations of the osteoid because of the vitamin D deficiency. So this is inadequate mineralization of the osteoid. Osteoporosis study is the decrease in bone mass. This one is inadequate mineralization of osteoid. Don't confuse, yeah? So what is osteoid? Osteoid is your bone matrix, which is secreted by the osteoblasts. Okay, so it is due to vitamin D deficiency, and bear in mind in children it causes rickets, in adult it is called osteomalacia. Okay, in children they still have these growth plates, so that's why when it happens in children, vitamin D deficiency happens in children since childhood, so it will affect the osteoid in the growth plate. Okay, so there will be abnormal bone. The contours of the bones will be affected, but this will not occur in the adult because their bone has been matured. So that is why they define they term there is a different in terms of the term to be called for the adult and the childhood. Okay, so this is the reasons. So in adults, the contours of the bones are not affected, but however, the bone, because of inadequate mineralization, the bone will be weak and they are vulnerable to fracture. And usually it will affect the vertebral bodies and also the femoral necks. Okay, before you learn about the pathogenesis of the rickets and osteomalacia, you have to know the vitamin D metabolism. Okay, you get your vitamin D from the sun, right? And from the diet. And it has to be metabolized in your body. So you get from these two, it will go to the liver, and this enzyme, the 25 vitamin D hydroxylase, will convert this vitamin D into this vitamin D, 25 hydroxylase vitamin D, and then it will go to the kidney. In the kidney, you have an enzyme called alpha-1 hydroxylase, which will convert the inactive vitamin D to the active vitamin D. Inilah active vitamin D, which is called the calcitriol or 125 hydroxy vitamin D. So you really need this vitamin D to absorb calcium from the intestine. Yeah, if you eat a lot of calcium but you don't have enough vitamin D, you cannot absorb the calcium that you eat, yeah, that you consume. So you need the active vitamin D, the calcitriol. So your liver, your kidney need to be good because you need to convert the inactive vitamin D to the active vitamin D to absorb the calcium. So this calcium and phosphate absorption will be used for the bone mineralization. So what happened in rickets and vitamin D? They are having inadequate vitamin D. So if you remember the metabolism, if I ask you the causes, you can immediately mention the causes of vitamin D deficiency. That is deficient in diet, limited exposure to the sunlight, if they have renal disorder, even if liver disorder, if they have malabsorption disorder, or if they have a genetically determined variants of vitamin D receptors. All these are the causes of vitamin D deficiency. All these diagram is from your Robbins, yeah? So what happened when there is vitamin D deficiency? So when there is a vitamin D deficiency, remember I told you, there will be reduced calcitriol, okay? So reduced calcitriol, so there'll be no absorption of calcium and phosphate from the gut, from the intestine. So in the blood, there'll be reduced serum calcium and phosphate. So what happened when our body is having hypocalcemia, our body will tell a gland at the thyroid, which is called the parathyroid gland, to normalize the calcium. Okay, the role of parathyroid gland is to normalize the calcium. So how does it try to normalize the calcium? It will mobilize the calcium from the bone, to normalize the calcium in the blood, and it will also increase the phosphate excretion from the urine. So there'll be reduced. The calcium can be normal sometimes, but it can also be reduced, and the phosphate will be, there will be hypophosphatemia, reduced phosphate, because a lot of phosphate is being excreted in the urine. That will contribute to the poor bone mineralization. Okay, so please remember this diagram. Please understand this diagram. You will understand the mechanism of rickets and osteomalacia. So this is just the what I've mentioned before. You need the active vitamin D to stimulate absorption of calcium from the gut, to stimulate calcium from the kidney, and to promote the mineralization of the bone. So vitamin D is needed for the mineralization of the osteoid, and it stimulates the osteoblasts to produce osteocalcin, which promotes calcium deposition. Okay. So when the body, this is a repetitive, when the body is deficient in vitamin D, they will have hypocalcemia. Hypocalcemia will cause release of parathyroid hormone. So it will cause mobilization of calcium from the bone, from the kidney. It will there will be active vitamin D to enhance the absorption of calcium from the intestine. However, there'll be increased renal excretion of phosphate. Remember the diagram before, and therefore the calcium can be restored to normal, but there'll be hypophosphatemia that will be persist. So there'll be mineralization of the bone will be impaired. Okay, so eventually it will result in unmineralized bone matrix. Just remember this diagram. This is a very nice diagram. Okay. Okay, morphologically, so if you look at the histology, this is the normal costochondral junction of a young child. You have a very nice palisade cartilage, palisade of the cartilage. Palisade is like they are making a fence, okay? So however, in those with rickets, the palisade of cartilage will be absent. It's not nice like this. So that is why they will have other features. This is another histological findings. This is the left side is the normal. Always look at the normal first, yeah? So you have, this is stained by a special staining. I'm not sure, I forgot what it is. So you have a very well mineralized bone here, and your osteoid is very thin. This is a normal bone. However, if in the patient with osteomalacia, the mineralized bone is there, but the osteoid will be thick because it is a unmineralized osteoid. Okay, so it will be appears as a thick osteoid. Okay, so for, as I mentioned before, osteomalacia, the vitamin D deficiency occurs in adulthood. So the contours of the bone is not affected, but the bone is very weak. That's why they will have pain. They will have increased fracture, risk of fracture. But as if it occurs in children, they will have rickets. So how does rickets manifest? They can have cranial tapes, whereby the flattened occipital bones. They can have frontal bossing, dahi jendul orang cakap, okay? Frontal bossing because of the excess of the osteoid. So they'll be producing a squared head, and then they can have rhotic rosary because of you have the costochondral junction here, you have the osteoid tissue there. So in rickets, there'll be overgrowth of the osteoid tissue at the costochondral junction, producing a rhotic rosary, and then pigeon breast, macam it's like the anterior protrusion of the sternum, because they have the metaphyseal areas of the ribs will be weakened, so that's why they're protruding to the front, so they can have like pigeon breast. Okay, and then they can have a Harrison groove here because of the inward pull of the margin of the diaphragm, and then the pelvic will be deformed, and when they stand up, they can have a bowing of the leg. So these are the features of the rickets. Yeah. Okay, this is what I mentioned before. In osteomalacia, contours are not affected, but bone is weak, vulnerable to fracture. So they can manifest with pain. Okay. So in terms of clinical manifestation, vitamin D can be low or normal, because if you still remember, low vitamin D will have low calcium, will stimulate your parathyroid gland. Parathyroid will try to will stimulate your 1-alpha hydroxylase, then increase the vitamin D. So it can be low or normal. Don't worry about that. Okay. Calcium bone can be low or normal, and phosphate will always be low. That's why it causes unmineralized bone. And the alkaline phosphatase, I've mentioned before, alkaline phosphatase is secreted by the osteoblast. So because increased compensatory osteoblast, so the alkaline phosphatase will be elevated in those with rickets and osteomalacia. And other tests just to rule out the vitamin D metabolism impairment, derangement. And for the X-ray, they can have a bowing of the legs and other features like I've showed before. So how to treat them? So you need to find the underlying causes why the patient is having vitamin D deficiency, whether this is renal causes, whether this is malabsorption or others. So need to treat the underlying causes and need to give the vitamin D supplement. Okay, that's all for the second topic. Now let's move on to the third topic, which is the Paget disease of the bone. This is the last topic. Paget disease of the bone is not so common, but it can happen. It is characterized by structurally disorganized, therefore it is susceptible to deformities and fractures. Yeah. So it usually begins in late adulthood, and it is characterized by abnormal remodeling and thickening of the bone. So it interferes with the remodeling process of the bone. And the prevalence is greater in males compared to the females. And then it more prevalence in the elderly groups. Okay, that is Paget. So current evidence suggests that the pathogenesis could be contributed by the genetic and environmental factors. Okay, approximately 50% of familial Paget and 10% of sporadic cases actually harbor mutation at this gene, this SQSTM1 gene. So when there is a mutation in SQSTM1 gene, there'll be increase in NFK beta, and because of this, it will increase the osteoclast activity. Okay, so these are the proposed theory of the pathogenesis of Paget. So it has high prevalence in Western Europe, like France or Germany. However, it is rare in native population in China and Japan. Because it is influenced, because the geographic distribution influence the numbers of the disease, so they suggest that some environmental factors may contribute to the development of the Paget disease of the bone. Okay, and some studies also found that the cell culture studies, when the osteoclast precursor were infected with virus like measles or other RNA virus, it will actually alter the vitamin D sensitivity, and therefore it will increase the bone resorption. Somehow it will increase the bone resorption. So these are still under study, and the findings were in the measles virus and other RNA virus. Okay, not sure whether COVID can also cause Paget. Not sure. Yeah? No research or no study done yet, if I'm not mistaken. Okay. So how does what are the special things about Paget? Okay, like osteoporosis is reduced bone density, rickets and osteomalacia, unmineralized bone, Paget is remodeling punya derangement. So what's special about Paget? They have 3 sequential phases. They have osteolytic phase, and then after that they have mixed phase, whereby there'll be osteolytic and osteoblastic, and then the last would be the osteosclerotic stage. So these are the special things about Paget. They have 3 sequential phases. Please remember this, yeah? So what happened in osteolytic? This is also from your Robbins. So in osteolytic, the name itself is osteolytic phase. So there'll be a lot of osteoclasts. Osteoclasts will be abnormally large and they are more than normal. Yeah. So in this stage, there'll be increased osteolytic activity. Okay. This is the initial state, initial phase. And then it will proceed with the mixed osteolytic and osteoblastic activity. So they're going to be a mix of osteoclasts and mix of osteoblasts. Okay, the bone surface will be lined by prominent osteoblasts, and there'll be numerous blood vessels. Nampak ni? These are the blood vessels. Okay, this is the osteoblast. This is the osteoclast. This is the mixed phase. After the mixed phase, it will proceed with the osteosclerotic phase. Meaning that in this phase, the bone resorption decline progressively, and eventually it will lead to hard, dense mosaic bone, which represent the so-called burnout phase of the Paget. So please remember this. In Paget, special about Paget, they have 3 phases. Osteolytic, proceed with mixed, and then osteosclerotic. Okay, the bone will be thick. Okay, so morphologically, the most significant and the most important will be the mosaic pattern, which occurs in sclerotic phase. So if you can appreciate, this looks like a mosaic to me, but some students say tak ada pun doktor. Okay, but I think this is like mosaic pattern, and this jigsaw puzzle, mosaic jigsaw puzzle. Okay, like appearance, and the bone is joined haphazardly actually. Okay, and this is happen in the sclerotic phase. So these are the characteristic, histological characteristic of Paget. So if you get this in the exam, please think that this is Paget. Okay, you cannot find mosaic pattern in other condition. Okay, so mosaic pattern, it occurs in the sclerotic. The initial phase, like the lytic, usually it is less specific, the findings, but you can have a lot of numerous large osteoclasts, right? Because it is osteolytic phase and resorption peaks. The osteoclast can be more than 100, and it will persist in the mid phase. Okay, but the more prominent would be the sclerotic phase, which is the mosaic jigsaw puzzle appearance. Okay. Okay, how does they manifest clinically? So there'll be in Paget, it will be monostatic in about 50% of cases, meaning that it will affect one bone, okay, in a minority of cases, 15%. Majority will be polyostatic. It will affect many bone, okay, and 80% will affect the axial skeleton and proximal femur. And most cases like osteoporosis, Paget also will be asymptomatic. Sometimes it was incidentally, it was an incidental findings during the radiographic examinations, okay, for other purpose. And then they can have localized pain. It is quite common. And the pain is actually due to the microfracture. So patient tak perasan, okay, microfracture, or by bone overgrowth that compress the spinal or the cranial nerve roots. Okay, so these are the clinical manifestation of Paget. Another manifestation, if the condition is severe, they can have enlargement of the craniofacial skeleton, so they can produce leontiasis ossea, or it is a lion face. So the cranium sometimes can be very heavy, so it will be difficult for the patient to hold the head erect. Okay, and then the weakened pediatric bone can also cause invagination of the skull base. Okay, this one, it is called the platybasia. Okay, the posterior fossa can also be flattened. Okay, and sometimes they can have a frontal bossing as well. Okay, so if you lion face, frontal bossing, think of Paget. In elderly, Paget usually happen in elderly and more prominent in males. Okay, another clinical manifestation, they usually have a chopstick type fracture. So this one is a frequent complication, and usually it occurs in long bones. Long bones means like the femur, the humerus, that is considered as the long bones. Chopstick type fracture, cantik je. Okay, and then they can also have kyphosis because of the compression fracture of the spine, result in spinal cord injury. And then because they have mixed face, right? At the mixed face, they have increased osteoblast, so they can have biochemically they can have elevated alkaline phosphatase. Okay, but their serum calcium and phosphorus will be normal. This is because usually in the because of the increase of the osteoblast activity, mainly at the mixed face. So other complications is just to recap, other complications that may occur in patient with Paget is fracture, chopstick type fracture tadi, usually in the long bone, and then another thing that can occur in Paget but not in osteoporosis and osteomalacia and rickets, they can have neoplasm arising from the pediatric bone, but it is rare. It occurs only 1% in individuals with Paget, and it is called osteosarcoma. Okay, so even it is rare, they still have the risk because these osteosarcoma can arise from the pediatric bone. Okay, and if you still remember the mixed space that I've shown you, there will be a lot of vessels. Okay, so there'll be hypervascularity of the pediatric bones. It will warm the overlying skin, and because increase in severe polyostatic disease when it affect multiple bone. Like what I've shown you, there'll be increase in vascular, right? Kat sini. So if it affects multiple bones, it will increase blood flow. So there'll be high output, there'll be increased demand of the blood. So there'll be increased workload of the heart. So they can have one of the complication will be high output heart failure, or if the patient already have underlying disease, it will exacerbate the underlying heart disease. Okay, so these are the complications of Paget: fracture, neoplasm, hypervascularity, and cardiovascular problem. Okay, I think that's all from me. Okay, any question? Class? Kalau tak ada, cakap tak ada, tak apa. I nak tahu ada orang dengar tak I cakap ni.
Tak ada doktor.
No, doktor.
Tak ada.
Okay.
So good.
Okay, very good. So all the informations that I've mentioned before is all in your Robin. Yeah. For the recaps, you have to go to the chapter 8, if I'm not mistaken. Chapter nutrition. Okay. So you have to look at the chapter 8 under nutrition, under vitamin D deficiency. For you to understand the mechanism of rickets and osteomalacia, please understand the metabolism of vitamin D dulu. Then you will know what are the causes. Then you will know how it affects the mineralization of the bone. Okay? If there is no more question, apa ni? Okay, that's all from me. Assalamualaikum.
Thank you.
Thank you,
Thank
Doctor.
you, Doctor.
Okay, bye.
Have a nice day,
Doctor.
Doctor.
Have a
Assalamualaikum.
nice day.
Doktor.